All right, everyone, we'll go ahead and get started. Thank you guys for coming to our first grand rounds of 2024. Really exciting. We have some great programming for you this year. So thanks for coming on this early January day. So today we have a great grand rounds presentation by Dr. Prather, a graduate from the University of Missouri, Kansas City 6-year medical school. Dr. Prather also completed her internal medicine residency and was a chief resident at UMKC. She then traveled north to Rochester, Minnesota for gastroenterology fellowship, where she also completed an additional year of motility training and clinical research. After 5 years on faculty at Mayo, she returned to Missouri for a faculty position at SLU, where she was a tenured professor with a gastroenterology and was the gastroenterology fellowship director for 15 years. She also received her MPH in epidemiology and biostatistics at SLU. And after a very brief retirement from SLU, she was recruited here to Washington University as a clinical gastroenterologist to build the GI pelvic floor program. In addition to her clinical responsibilities, she served on the ABIM Gastroenterology Exam Committee for the past 10 years, serving as a chair, and is the current chair of the Longitudinal Knowledge Assessment Exam. Dr. Prather has spent her career caring for patients with disorders of gut-brain interaction and pelvic floor dysfunction and enjoys mentoring junior faculty and trainees for careers in academic medicine. Today, she will present grand rounds on constipation and pelvic floor dysfunction. Let's welcome Dr. Prather.
Thank you so much for having me. I'm going to stand a little bit over to the side, a little bit height challenged and often can't be seen over the podium. Well, thank you so much for that kind introduction. It's been a lot of fun chatting with you. Yes, no daggers this way. I am the inaugural chair of the Longitudinal Knowledge Assessment Program for ABIM. Happy to dispel any myths about that or to talk to you about it. I'm actually pretty enthusiastic about the program. And especially if you'd like to get engaged with ABIM, we're always looking for people who like to get engaged in different aspects and would be happy to talk to you about that and opportunities there. That also brings me to my disclosures. I have no consulting or financial conflicts, pretty squeaky clean that way. I am required to let you know that I am on ABIM and that I will not be talking about any test questions. I will discuss the off-label use of medications for the treatment of constipation, including misoprostol and tenapanor. Tenapanor is actually FDA approved for IBS, but weirdly not for constipation. Well, let's start with what is constipation, because we need to kind of start from a framework that we're all on board. And we aren't always on board with our patients when we just talk about specific terminology. Well, we can start with a Google search, and it's not terrible. A condition in which there is difficulty in emptying the bowels, usually associated with hardened feces. Well, okay. Or a high level of constraint or restriction, a pronounced lack of ease. And the synonym is obstruction. Not something that we always think about, but indeed, obstruction is an important concept for us to understand when we think about constipation, particularly in patients who may not be responding to therapy. And self-reported constipation is incredibly common, affecting 12 to 26% of adults. The percents, when we're taking a look epidemiologically at how common something is, really comes down to the definitions that we use. So you'll see anything ranging from 10 to 20% in most epidemiologic studies. When we talk about constipation, we have in our minds what we think constipation is. But what do our patients think? In this study that took a look at a large number of patients with constipation, they looked at what were the most important symptoms that the patients had. And as you see, infrequent stools, which we as physicians think is most, we like numbers, is the thing that we mostly look at, straining, hard stools, and incomplete evacuation are much more of an issue for our patients. In fact, many of them say that they have a daily bowel movement, but it's really the difficulty with having a bowel movement that is the important symptom. So always exploring a little bit more. Well, tell me what you mean by constipation, as opposed to the next question we often ask is, well, how many bowel movements do you have? So again, understanding what our patients are saying is certainly going to be important. More recent studies show that the global amount of constipation that we see epidemiologically is around 12%. And of that group, using the current Rome 4 criteria for diagnosis, is about 1.3% for IBS with constipation. So constipation in general is much more common in the general population than irritable bowel syndrome with constipation is. Clearly, there's some overlap in those symptoms. Importantly, most of those patients don't even come to medical attention, less than half. When they do, they've typically already failed the things that we often recommend first line, such as diet, lifestyle measures, and usually 2 or 3 over-the-counter treatments for this. And so we need to explore that a little bit as well, because when we make recommendations, our patients are going to be disappointed when we tell them, increase your dietary fiber. Not that that's not important, but we do need to give them either specific information that's relevant for them or take them to a next step beyond what they've already done. Now, when we think about constipation, I'm really referring to chronic constipation, symptoms that have been present for 3 months or more, typically 6 months, 12 months, much longer. The categories that we like to think about with chronic constipation are really kind of fourfold. Functional constipation, that means constipation without a structural reason, some other reason for it. This is the current Rome 4 terminology. Now, Rome 5 is getting rid of the functional terminology, so this is going to change in the next year. But I still like the functional term. It's just that it's gotten to have a little bit of a pejorative sort of meaning to it. But to me, functional means that there may not be a structural issue, but clearly the function is not normal. And so I'll use that terminology with the patients just to kind of help them understand that this is an important problem and that it's not something that we're just blowing off. I spent a career taking care of patients with IBS. I see plenty of patients with IBS with constipation. Certainly drug-induced constipation is quite common. We see this very often. Opiate-induced constipation, not focusing on that a lot with this talk, but certainly an important condition as well, for which we have new treatments. And something that I want to introduce some of you to that you may not already be aware of is defecation disorders, particularly as it relates to constipation, because it's important to diagnose it, and it has effective treatments that really will help your patients. So chronic constipation, by definition with Rome 4, means symptoms that have been at least 6 months with active symptoms in the past 3 months. When we think about the criteria that they use, it's important to know this because our current medications have been approved using some variation of the Rome criteria. So symptoms in the past 3 months with an onset more than 6 months ago, with 2 or more of the following features: straining, lumpy or hard stool, incomplete evacuation, a sense of anal rectal obstruction, the need to use manual maneuvers, splinting the perineum, digitation of the anus, or defecation less than 3 bowel movements per week. The stool should rarely be loose, less than 20% of the time unless they're using laxatives, and they should not meet criteria for irritable bowel syndrome. Clearly, patients with constipation can have some discomfort and can have some bloating, but pain is not the predominant symptom, which is what we see more commonly in irritable bowel syndrome. And again, certainly overlap, but it's, we do define it differently for the purposes of clinical trials. So let's start with some truths or myths about constipation. True or false, constipation as a medical condition really isn't that serious. It's really not associated with many adverse health outcomes. Well, obviously I wouldn't be here if I didn't think this was an important condition, so that's clearly false. And in fact, we've got several different studies that show the adverse outcomes that constipation, even when controlling for other factors, has. Between 2006 and 2011, there's been almost a 42% increase in emergency room visits for constipation. Interestingly, a study that was done by a cardiologist took a look at constipation as it related to adverse outcomes in his patients with atrial fibrillation and heart failure. And he found that there are actually adverse cardiovascular effects, not only with constipation, but especially with the use of laxatives. And in this graph to the right, what you see is that over this period of follow-up of 6 years, the patients with constipation using laxatives with heart failure or AFib were much more likely to develop serious complications of bleeding. Again, epidemiologic study, retrospective, certainly not definitive, doesn't say that laxatives cause the increased bleeding or the constipation, but is certainly interesting and gives us kind of food for thought in our approach to these patients. And constipation in this large epidemiologic study was associated with increased mortality. And this was out to 15 years at 73% versus 85%. So certainly, constipation is an important problem that does have the risk for adverse health outcomes. Again, it may be partly a marker for adverse health. People with more medical conditions may be more likely to have constipation, but certainly an important condition for us, to consider. Well, what are some of the causes of constipation? Well, there's a long list of different etiologies. Certainly, we focus a lot on lifestyle factors, but you can see the list here. Certainly not all inclusive, but many different things for us to think about and explore with our patients. Well, let's look at the first one, lifestyle factors. This is something that we often recommend. More fluid, more fiber, more exercise. Well, these are certainly super healthy things for us to be doing. We all could use a little bit more fluid, I think, especially, we tend to be a little bit dehydrated ourselves as we're rounding and not taking time to drink our water. Fiber, well, the average American gets about 12 grams of fiber per day. We're pretty average, I think. The American Dietetic Association recommends 25 grams on average. So we all could use a little bit more fiber. And, it's January, healthcare resolutions in full force. I think many of us are working on trying to increase our exercise. I restarted the Adrian Yoga 30-day challenge, and so, I'm right there with everybody else with that. It's quite good, I might add. Great way to get started. So this brings me to myth 2. Does increasing fluid intake increase stool frequency? How many times have you recommended this for your patient? Drink more fluids, it's gonna help your constipation. Is that true or false? Well, in fact, that's false as well. In this study, which is a small study, only 15 patients, but they compared water versus Gatorade. Period 1 is baseline. Let's see if I can get this right here. Period 2 is 1 liter of extra fluid. Period 2 is 2 liters of extra fluid. And then period 4 is back to baseline. The top part is stool weight. The bottom is urine output. And what you can see is that there's no change in stool output with increased isotonic fluid, Gatorade. There is, as you can see, with the 2-liter increase down on the bottom part, an increase in urine output. So same was true for water as well. No change, although the increased urine output in period 3 at the bottom did not reach statistical significance. So in general, increasing fluid output an additional 2 liters per day did not improve stool weight, but it did cause more urination. So if you're increasing your patient's fluid intake, they may not have more stools, but they may have to urinate more, and they may or may not be happy about that. So, and certainly this is not referring to people who are already dehydrated. If you're dehydrated, certainly getting more fluids in is going to be important. Well, what about exercise? Exercise is definitely associated with less constipation. In this study, taking a look at it, compared to less than once weekly, which is 1, those who exercised once per week, 2 to 3 times, 4 to 6 times, or daily, that there's a progression reduction in the likelihood for having constipation. Again, epidemiologic study, association is not causation, but those who are more active are less likely to be constipated. What about fiber? Similarly for fiber, and as you see, 7 grams, 10 grams, 12.5, 18, 20, the more fiber intake you have, the less likely you are to be constipated. So certainly there's good rationale, at least for the fiber, at least for the exercise, as to why we might recommend those. Fluid, maybe not so much. Medications, we talked about medication-associated constipation. Our patients are on a variety of medications that tend to contribute to constipation. Going to have a word about NSAIDs. We're familiar with opiates causing constipation, but what about other medications that we use for pain? Then I also highlighted at the bottom, many more of our patients are on the GLP-1 agonists, and so certainly we're seeing more GI symptoms related to that. Constipation is certainly one of those. Well, this brings us to myth 3. Non-narcotic medications are going to be better than opiates. Acetaminophen, NSAIDs, and aspirin are not really associated with constipation. True or false? Well, in fact, that's false. Chronic constipation is associated with the use of acetaminophen with an odds ratio of 2.7. Even aspirin, again, the confidence interval being, my interest in statistics, it's right there at 1. So not, the strongest evidence, but still suggesting even aspirin and even NSAIDs are more likely to be associated with constipation. Again, these are association studies. It doesn't necessarily mean that the medication's causing the constipation. We do our best to control for factors that we think might be, contributing to the outcome of interest that we have. But certainly food for thought that when we put people on these medications, that constipation is something that may happen. In this larger study, in this next graph, I just want you to focus on this box over on the right. The number of constipating medications that a patient is taking increases their likelihood of having constipation. So 1 is our comparator. 2 is 1.3 odds ratio. 3 is 1.7, and 4 or more is 3.5. So as you add medications that are constipating, even if at baseline it's really not too bad, they certainly are more likely to develop symptoms. And a recent patient that I saw in clinic was on a variety of medications that can be associated with constipation, including amlodipine, diuretics can be, hydrochlorothiazide, was taking an antihistamine, again, ceftriaxone, not too anticholinergic, but certainly has some constipating features. For a bladder, was on a medication and was taking an NSAID. And certainly, talking about is it appropriate to continue these medications? Are there opportunities for improvement? So medications are something to delve into the history. So what are the other things that we take a look at with history? Well, certainly if you're not eating, you're not going to be having bowel movements. If all you're drinking is a dietary supplement and not getting in so-called real food, you may not have regular stools. So we're going to review food, fiber. I'm a fan of asking for a dietary recall for the past 24 hours. Tell me what you had to eat yesterday. People honestly don't change their diets that much from day to day. They'll say they're eating a lot of fruits and vegetables, that they've really increased their fiber, but you really have to kind of get into the weeds and detail, like, are they actually getting their greens, and which greens are they getting? Iceberg lettuce does not have a heck of a lot of fiber in it. And so you do have to really, help them see that what they're doing may not be quite enough. Let's see. Of these questions, one of the areas that I find the most helpful is to get an idea of what does their stool form look like when they are not taking laxatives. And this is our so-called Bristol stool form scale. We know that those with the hardest stools, type 1, little ball-like stool, which is the most common stool form that my patients with constipation describe, are more likely to have slower transit. Now, fiber can increase transit, so that doesn't necessarily mean that they have slow colon transit, but that we need to do something to try to improve their stool form. We're going to talk a little bit about pelvic floor dysfunction. Even the best pelvic floor function has a hard time passing small, hard stools. The next part is our exam. And I'd especially encourage the residents, and I require my fellows, to do rectal exams on patients that have constipation. And this is not just putting your finger in the bottom, feeling for a mass, and heaven forbid, the test that I got eliminated from SLU that I'd like to get eliminated here is the fecal occult test in the hospital. It has absolutely no value for that. We need to stop doing that. That should not be part of your rectal exam. It was never meant for that. So you're going to inspect the skin, look for evidence of anal fissures. You're going to look for the perineal descent. What's perineal descent? Well, with straining, the perineum should move down 1 to 3 centimeters. Not moving at all is abnormal. Excessive movement is also abnormal. So perineal descent is important. Certainly when they strain, before you put your finger in the bottom, especially when they complain of abnormal fullness, you can look for prolapse. Again, it's better to look at prolapse when they're in the seated position. If I'm concerned about prolapse, I actually will examine them in the seated position, typically over a commode. On exam, digital exam, I'm going to assess their baseline tone, ask them to squeeze, relax. Sometimes they have to do that a couple of times to understand what you're saying. I'm going to have them strain. During strain, you'd like to feel the sphincter relax, and you can actually feel that. If there's stool, I'll assess the character of the stool. Certainly if there's a mass, I'm going to assess for that. And then to assess for rectocele, typically we have our finger, in our patient's bottom. Typically their head's here, their legs are here. The vagina is actually anterior. So to examine for a rectocele, you actually have to turn your hand the other way. Examine the anterior wall of the rectum at rest. With strain, the anterior wall falls forward. Now, a rectocele in and of itself is not necessarily a problem causing constipation, even though your patients may be very concerned about that. It's usually the result of multiple years of straining, and so the problem is to fix what's going on in the pelvic floor, not necessarily to fix the rectocele, unless it's truly obstructing and preventing stool outflow. And on this exam, this kind of shows you the different anatomy that we're taking a look at during our exam. And you can see the puborectalis in addition to the anal sphincter. The puborectalis is just a little bit higher, but needs to relax as well. So, I tell you to do this exam, but how good is it at identifying patients that might have problems with the outlet as contributing to their constipation? Well, actually, it's pretty good. It's got a positive predictive value of 97% in identifying patients who have pelvic floor dysfunction. And it has a negative predictive value of 91%. So I might be wrong 10% of the time, but it's actually pretty good. And it doesn't take very long to get good at doing this rectal exam. And it gives you a lot of information for your patient in helping to understand why they might have constipation. Well, we've seen our patient, we've done our history, we've done our exam. What are we going to do for our patients next? What's going to be our management? Well, we've talked about our lifestyle factors, the pros and cons related to that. I am a fan of fiber. I do try to get my patients on a healthy diet, reducing their processed foods. Certainly that's going to be important. But I try to make recommendations. They're going to work with what I understand about my patient and their current lifestyle. Fiber improves transit time and frequency. Now, fiber is a great challenge. And if your patient's really already been on a good amount of fiber that you've gleaned from your history, it can tell you a few things. You want to think about, does my patient have medication-induced constipation? Fiber doesn't help slow transit constipation. I mentioned that fiber enhances transit. Well, that's true in a normal colon. If you have slow transit constipation, more fiber is not the answer. And importantly, the area that I'm most interested in is that more fiber does not help your patient with outlet constipation, what we call dysynergic defecation. I actually hate that word. It's just kind of so clunky. But dysynergia just means incoordinated muscles involved with defecation. Unfortunately, fiber is associated with some side effects, including bloating and gas. So you often will have to have them increase their fiber slowly. I like to show this next graph to my patients to kind of get them an idea of what 25 grams of fiber might mean. And I usually get a pretty good laugh about this, including the bottom one that, just eat 2 Taco Bell bean burritos per day and you've got it made. But certainly helping them with some concrete suggestions with their lifestyle of how they can increase fiber is going to be important. What about fiber supplementation? It's certainly appropriate for mild to moderate constipation. The studies aren't necessarily the best. Brand, 2 positive, 1 not so great. A little bit more evidence with psyllium husk, some with methylcellulose, but not much data. 1 RCT with guar gum, 1 with calcium polycarbonate. The key is to pay attention to the amount of fiber. Your patients want to take gummies, they want to take tablets. At most, those have half a gram of fiber. A lot of them also have sugars in them as well, which may or may not be good for your patient. Recognize that soluble fiber seems to work a little bit better than insoluble fiber. Insoluble fiber, for example, is wheat bran. And just recognize that if fiber isn't working, more isn't better. Well, many of my patients don't want to take medications. What are other options? Well, you know what? What our grandma said about prunes is true. We actually had a randomized controlled trial that was done on 50 grams of prunes twice daily, which is about 5 to 10 prunes. And, it has a robust number needed to treat of 3. Similar for osmotic laxatives. We have lactulose, sorbitol, which is equally effective to lactulose, magnesium salts, and polyethylene glycol, 3350, what we know as Miralax. They all work by increasing fluid in the gut. The poorly absorbed sugars, the lactulose and sorbitol, can cause some increase in bloating, but they do work. Polyethylene glycol 3350 is the best tolerated, although the volume in drinking a liquid can be a problem for some patients. This is one of the randomized controlled trials with PEG 3350. What I like about this study is that it was taken out to 6 months. These problems are chronic problems for the patients. A 2 to 4 week trial really isn't enough. And in both the intention to treat analysis and even when we break out the separate group of elders, you can see that the response with PEG, with the light yellow bars, is certainly much greater than with placebo. Stool frequency also increased from 6 to 8 bowel movements per week. Again, this study was done about a little over 10, 15 years ago, but the data are still true. Now, osmotic laxatives are usually my first go-to after lifestyle factors, but I don't necessarily jump to prescription medications next. Stimulant laxatives are not the big, terrible thing that our patients have been made to believe. And many of our patients come to see us because they're afraid of taking laxatives and becoming dependent on them. And there is tolerance certainly that can develop with these. In melanosis coli, we see it all the time, the dark stain that occurs in the colon. But stimulant laxatives actually have some pretty good efficacy. The ones that we have in the US are Senna, Cascara. Aloe is actually a stimulant laxative, and bisacodyl. Now, unfortunately, there's very few randomized controlled studies. Lack of evidence certainly doesn't mean lack of efficacy. Yes, they can cause side effects of cramping and abdominal pain, but they may be reasonable, cost-effective options for many of our patients. Most often, they've been used kind of as rescue. Now, we do have 1 and now 2 randomized controlled trials with bisacodyl, the one that's most commonly available over the counter. Average age of the patients was 55 years, 10 milligrams, which is 2 tablets versus placebo. It was effective and it was well tolerated. If you take a look at the graph on the right, we can see that compared to baseline, marked improvement on bisacodyl. As is true with many of our laxatives, the first week effect is usually much better with a little bit of a decrease effect over the next few weeks. This is true with many of the prescription medications that we use for constipation as well. Your patients will say it worked great at first, but then not so well. Well, I kind of warn them that you're going to get your best effect in that first week or 2, and then it's going to kind of level out to your new baseline. So they don't necessarily expect that same early effect that they see with this. So bisacodyl is certainly something that's reasonable to use for our patients, and it's cost effective. Well, moving on to our prescription medications, there are quite a few new kids on the block, with this. So I'd like to review those because these are things that your patients may ask about. I know they can be a little bit challenging to get through insurance companies, and they are quite expensive, which is why they aren't always my first go-to. The first is secretagogues, our pro-secretory agents. This includes the chloride channel agonist, lubiprostone, and the guanylate cyclase C agonist, linaclotide and plecanatide. First, lubiprostone, a respectable number needed to treat of 5. Certainly not quite as good as our osmotic laxatives, our stimulant laxatives that we talked about already, but recognize that the patients that are in the randomized controlled trials typically failed those agents already. So lubiprostone works by increasing intestinal fluid secretion. It improves spontaneous bowel movement. So again, for the purposes of clinical trials, we want a spontaneous bowel movement. You didn't need an enema, a suppository, or another agent in order to have a bowel movement. Sometimes you'll hear the term complete spontaneous bowel movement. Not only did you have a bowel movement, but you felt like you did the whole thing. There isn't anything left there to go. There have been at least 6 randomized controlled trials with lubiprostone, all confirming efficacy. Linaclotide, the guanylate cyclase C agonist that first came out, activates guanylate cyclase C receptors, increasing secretion into the colon. And the nice thing about these secretagogues is that they have minimal systemic absorption. The effects are really focused in the gut, which means minimal interactions with other medications. 6 randomized controlled trials with this. If we take a look at the next slide, we see a prompt increase in improvement, which is maintained for the 12-week period. And in the crossover, the patients also responded as well. Those that were crossed over to placebo went back, not quite to their baseline, but had a reduction in stool frequency as well. Now, as you take a look at the top line, you see kind of the squares and the triangles. Note that those are the 2 different doses, 145 and 290. One of the things that you may notice, for example, linaclotide has 72, 145, 290. Doubling the dose does not double the effectiveness. And this is true of many of the agents that we use for motility disorders. So you can't say that, oh my gosh, we're gonna, double the dose, it's gonna be twice as effective. You get maybe a smidgen of an increase, but it's not a lot. So there's not a huge advantage of one dose necessarily over the other. I'll usually start in the mid-range. If they get diarrhea, I'll go down. If they isn't quite effective, I may go up, knowing that I may or may not get a boost with that higher dose. Plecanatide, very similar to linaclotide. Not a whole lot of difference between the 2 in my mind. You see a very similar graph. Again, take a look at the top. You see the 3 milligram dose versus the 6 milligram dose. Honestly, not a huge difference between those 2. So higher doses are not necessarily more effective. Now, I mentioned that I did some motility. That's one of the things I like to do. I would love to have prokinetics that help with constipation. We had one many years ago, a 5-HT4 agonist to Gastroenterology that's not readily available now. Our current 5-HT4 agonist is precalopride. Precalopride, I actually studied this. I did the initial some of the initial phase 2 studies like more than 20 years ago. But it didn't get approved initially because tegaserod kind of was already, out on the market. But precalopride actually has some pretty good prokinetic effects. Now, as you can see in this study, the 2 milligram versus the 4 milligram dose, there isn't a huge difference in effectiveness. In fact, on the graph on the left, it looks like it's a little bit, less effective. On the right, maybe a little bit more effective, but not really statistically significant. But precalopride definitely improves the rate of complete spontaneous bowel movements. It does have some mild prokinetic effects in the upper gut as well, including the stomach, but it's not approved for gastroparesis. And honestly, it's a very difficult medication for us to get clinically, even though I like that we now have a prokinetic that we can use. The new kid on the block is tenapanor, a sodium hydrogen exchanger isoform 3 inhibitor. It's approved for irritable bowel syndrome with constipation. No reason to think that it doesn't work for regular constipation as well, but you're not going to get it for that. It blocks dietary sodium absorption and retains luminal fluid. It accelerates transit, and it softens stools. And you're seeing another graph for efficacy that looks pretty similar to the other ones. Now note, I didn't really talk about the placebo response rate. As you take a look at the empty square boxes, you see that even giving a placebo, when controlling for everything else, patients do still get better. And this is honestly where I'm hoping that my lifestyle factors, in addition to maybe having some efficacy, that I'm also, kind of helping a little bit with that placebo response rate of helping them to improve. Well, I've talked about medications. There actually is a device that helps constipation. It's a revolutionary chemical-free vibrating capsule. And you can see the little capsule right there. This was something that one of my colleagues, Eamon Quigley, was very involved in the randomized controlled trials. He's also a motility specialist. So you take this capsule, you can turn it on, it vibrates and somehow accelerates transit. In this study that was done, the change from baseline mean complete spontaneous bowel movements during the trial period of 8 weeks, you can see an increase with a vibrating capsule compared to placebo. I actually haven't recommended this for any patients yet. I'm intrigued about it. I have a little bit of problem about putting more indigestible waste into our waste system, and I don't know, maybe I'll think about it. I do find it fascinating. Maybe it'll be something I'll try for a patient in the future, but your patients may ask you about this. Just briefly about opioid analgesics, not focusing on this today, but there definitely are PMORAs, peripheral mu agonists, that are helpful for managing our patients with these symptoms. Well, I'd like to transition now to something that doesn't work. Docosate sodium, something else I'd like to get off our formulary. And there's even a study last year that was presented, things we do for no reason, prescribing Docosate for constipation in hospitalized patients. We don't have one. We have several randomized controlled trials that show that this does not work. Now, it's safe, it's cheap. If my patient's on it, they think it's help, I talk to them about it, but I don't necessarily make them stop it, but I certainly don't start it. So what does work? Well, we've gone over the things that work. And these are the relative costs. I've actually got some other costs later on in the next slide to show you our prescription medications. But look at these over-the-counter options. These are pretty cost-effective for our patients. What happens when we move to prescription medications? And I just looked this up yesterday. So these are the costs as of yesterday. And I haven't spoken about misoprostol. Misoprostol is a medication that's used to prevent ulceration in patients on NSAIDs. Its main side effect is diarrhea. I mentioned that NSAIDs can be associated with constipation. If I have a patient on an NSAID anyway, this may be an option for something for me to consider. I mentioned dietary factors. There is one other food that is worth a mention. Again, the data aren't super strong, but if patients don't want to take a medication, eating a couple kiwi a day, or compared to taking psyllium, they can increase your stool frequency and your ease of passage as well. Well, I've kind of gone through kind of our standard of how do you manage constipation. That's not typically what comes to see me in the office. This is where we get to the point where you might start thinking about a referral. And this is in our patients with refractory constipation, not responding to kind of the conservative measures, maybe a first-line prescription medication. And these are the patients that are going to benefit from additional physiologic testing. What testing do we have available? Well, the first one is a simple one, balloon expulsion testing. Nobody does this in the office, but it's like super easy and cheap. Balloon, little tubing attached, you put it in somebody's rectum, you fill it with 50 mLs of room temperature water, sit them on a commode. Most people can honestly expel it in less than 20 seconds. More than 60 seconds is considered abnormal, and is a good screen for pelvic floor dysfunction. It would be nice if we could just do this in the office, but I guess we can get paid based on time, but there's no code for doing this particular test, so we usually do it in conjunction with our anal rectal manometry. Colon transit, super easy. I put patients on a standard fiber supplement, 5 grams per day. They have to abstain from laxatives during this time and enemas. They take a capsule with 24 markers on day 0. I get an x-ray on day 5. It's abnormal if 5 or more markers remain. In this example, you see a whole bunch of markers down there in the pelvis. Again, people used to say, oh, it's on the pelvis. This has to be pelvic outlet dysfunction. Maybe, but not necessarily. It's really not that good at differentiating the type of constipation, but it does tell you that the transit is slow. And this brings me to, the pelvic floor dysfunction. Now, pelvic floor dysfunction is a generic term that's also going to include like urinary-related symptoms or bowel incontinence. But when it relates to constipation, I'm specifically referring to dysenergic defecation. These are the symptoms that patients often complain of. Unfortunately, dysenergia cannot be reliably diagnosed by those symptoms because they overlap significantly with both normal transit and slow transit constipation. Except there was one study that did take a look at the presence of liquid stools and a sensation of incomplete evacuation may be predictive of dysenergia. So your patients that you put on linaclotide and they get diarrhea, but they still feel like they're not emptying completely, think that that patient may have dysenergic defecation. Well, what is dysenergia? Well, in a normal strain maneuver, your intrarectal pressure should go up and your anal sphincter pressure should go down. We measure this on anal rectal manometry. In this example on the top line is the balloon. You see the yellow, that's where the balloon pressure is going up from the rise in intrarectal pressure. The anal sphincter pressure on the left, the red, higher at baseline. During strain, we actually see some perineal descent. We see cooler colors green right here, showing good relaxation. Compare that to the bottom, where we see, again, an increase in pressure in the balloon. But the perineum here actually doesn't descend, it rises, and you can see the sphincter pressure goes much higher. So this is an incoordination of the muscles involved in defecation. We can look at this also with defecography. We actually still do this out at West. We don't do this all that often anymore. It's kind of an embarrassing test. Radiation involved, invasive. I do this when I'm more looking for a structural abnormality beyond dysenergic defecation. Anterior to the left, posterior to the right, you can see the sacrum. On the right, with strain, what you see is almost a donut right here area, where there's some intussusception actually inhibiting emptying of the rectum. And so it does give us some information about that. I've mostly moved to MR defecography. We also do this out at West, which gives us just beautiful images. Yes, it can diagnose dysenergic defecation, but it also gives me information about structural abnormalities that might be contributing to their emptying abnormality. Well, so we've diagnosed dysenergia. What do we do about it? Well, we do pelvic muscle physical therapy. We have an abundance of physical therapists here at Washington University, at Missouri Baptist, and there are some at West, although there's some transitions that have happened there, so not quite as many. We actually have some even over in Belleville on our Barnes facility. We have some excellent pelvic floor therapists. We compared here in the bottom right, pelvic floor therapy, which includes biofeedback, to sham, which was actually Kegel exercises, or standard therapy. And there's a marked improvement in symptoms with a 70% or greater success rate in reducing obstructive symptoms, increasing the frequency of bowel movements, and it's free of morbidity. Well, people have also asked, what about muscle relaxers? What about Valium? What about Botox? They don't work. Again, might get a placebo response rate, but I don't recommend any of those for the management of this condition. Well, what if it's not dysenergia and they have slow transit? Well, one of the things I do is I avoid fiber. I will double or triple up their laxatives if necessary. And those that aren't responding, that are truly disabled by their symptoms, subtotal colectomy with ileorectostomy actually works pretty well. 90% success rate. However, even in my practice, well less than 10% go on to surgery. Really get a second opinion before you send a patient for a subtotal colectomy, because it is an invasive procedure that does have some complications as well, and you want to make sure you've got the right patient. If they don't remove all the colon, it doesn't work. If they have an excluded pelvic floor dysfunction, their symptoms are just going to come back. What if they have both? Well, if they have both dyssynergia and slow transit, make sure you treat that dyssynergia first. Well, I'm going to conclude here. Let's first talk about the myths. More fluids means more urine, not more stool. Let's not recommend that anymore unless our patients are dehydrated. Fiber clearly works for some. Give some specific recommendations for your patients. But think about outlet dysfunction, dyssynergic defecation, or slow transit constipation, probably medication-induced constipation, if that doesn't work. Docosate sodium, please don't bother with that anymore. What does work? Well, we have our osmotic laxatives. That's what I go to first. Over-the-counter medications. While I'm ramping up my osmotics, take a bisacodyl, 1 or 2 every 2 to 3 days if you don't have a bowel movement. You can talk about adding in some prunes, kiwi, psyllium. We certainly have some randomized controlled trials that help that. For our patients that don't want to use medications, that want dietary intervention, I'm happy to recommend these. We talked about the secretagogues, prokinetics, sodium hydrogen exchange inhibitors. Those are really going to be directed at this day and age by what insurance covers. What if that doesn't work? I want you to think about pelvic floor dysfunction and slow transit constipation and refer for anal rectal manometry and or GI consultation with me and consider colon transit testing. So thank you so much for your attention. I've got our CME codes next, and I am happy to answer any questions that you may have. We've got a few minutes left.
Charlene, thanks so much for taking a difficult topic and really helping everybody understand what the options are. We have time for a few questions. Janet?
Thank you so much for that. I just have a question. You know, when you look at your randomized controlled trials, the fact that the placebo is actually impressive in many of the ones that you show. Could you give us some clues as to what you think might be going on in terms of, like, obviously they're enrolled in this RCT and there's lifestyle changes. What lifestyle change do you think has the biggest impact?
What a great question. The question is about the placebo response rate. And we see this placebo response rate with nearly everything that we do with motility and functional bowel disorders. It's incredibly, common. We don't necessarily know the answer to that. One of the things is that some of these are self-reported symptoms, and they're seeing either their nurse coordinator or the research physician. They want to please them. There could be a little bit related to that. It could be related to an improvement in autonomic function, feeling better, more relaxation. We don't really know the answer. Conversely, equally interesting to me is what about that nocebo effect? What about our patients? No matter what we do, they tend to get worse with these symptoms. I think that's a great area that we do need further study, and I'm super interested in. I saw Dr. Alpers in the audience. I know he certainly has a lot of knowledge in this area and has certainly thought a lot about the placebo response rate as well. Do you have a good handle on what is beyond that, maybe contributing to that 30, sometimes even 50% improvement that we see with placebo in these disorders?
Well, it all depends on your patient. And as you know, there's lots of psychiatric disorders associated with many of these things. Again, not necessarily causing, but associated with them. And I initially thought the more psychiatric illness you had, the more you might respond to placebo, but in fact, the reverse is true. So depending on the background of your patient and depending on their relationship to you and their response, that's going to have a big effect on the placebo rate. And those are not handled very well in randomized controlled trials.
For sure. For sure. And Dr. Alpers brings up a good point and something that I probably should incorporate into my talk, especially with the pelvic floor dysfunction. A good number of those patients do have a prior history of trauma. Now, if we're honest, we don't always ask about this. This is true in many of the conditions that we see in medicine. So as I'm mentioning, yes, examine your patient, yes, do a rectal exam. Always ask your patient, is this a good time for me to do this? This is why I do it. This is the information that I'm going to get. And always have a chaperone in the room with you when you do that exam. And make sure that your patients know that this is a safe place to discuss concerns that you have and that we have resources to help you if that is something that you're struggling with. So a question about particularly in children who have the trauma of having a painful bowel movement, which can result in a fissure or pain, and then develop withholding. Yes, incredibly important condition, very real. I don't know that that's the onset of adult-related pelvic floor dysfunction, but clearly that is a condition. The first thing you have to do is that if they have that overloaded rectum, you've got to get that rectum emptied out. And then you've got to get them on a regular regimen so they don't have a painful bowel movement again. So yeah, that's a little bit of a separate condition, but very important and something to be aware of. Children also can have anatomic abnormalities that we didn't talk about. Hirschsprungs we didn't specifically talk about, but certainly usually presents in infancy, but I've diagnosed it in adulthood as well, but certainly something to consider, in those situations as well. So thank you for bringing that up. All right, well, thank you very much.